Now I invite Dr.Leila Mohan for a talk. That child referred from neonatologist as abnormal red reflex. Is it congenital cataract? Dr. Leila Mohan is the Chief of Pediatric Ophthalmology, Contrast Hospital, Calicut.
Thank you, Dr. Ashok. Thank you, Dr. Anita, for including me in this session, which is very important. The abnormal red reflex, is it cataract? So, observation of red reflex is a simple way to detect any gross amblyogenic issue in an infant. Media opacities like cataract, corneal opacity, which need immediate attention, and also high refractive errors, strabismus, or any intraocular tumors also can be screened by a red reflex screening. And light passing through the media, the tear film, cornea, aqueous humor, lens reaching the retina and then back, any opacity like corneal opacity and cataract shows as a dark dull reflex, and is any asymmetric refraction. As you see in this first case, there is a light crescent superiorly which shows that it is a hypermetropic, high hypermetropia. Here there is a brighter left red reflex which shows that there is an strabismus. This is esotropia. Asymmetric reflex right is brighter, meaning it is anisometropia, right being the more ametropic one. And this yellow reflex is that of a retinoblastoma, yellow-white, chorioretinal coloboma. All these can be detected by doing, as Dr. Anita has already pointed out, red reflex screening test is ideal in the neonatology department as soon as the baby is born. So, a neonate with, is it cataract? Should the child be seen immediately? So, it all, in a child who is referred, whether an immediate intervention is needed or not, it all depends upon whether it is total, partial, bilateral, unilateral. In this case, where there is a bilateral total cataract, where there is no reflex, red reflex at all, it's a bilateral case. Here you can see the red reflex in one eye, the other has a partial cataract. So a total cataract, whether it is unilateral or bilateral, it may all come down to timing. So it's an emergency. Very few cases in a newborn are considered emergency. So the child is said to lose one line of visual acuity for every 3 weeks, that the surgery is delayed in the first 14 weeks of life, as shown by Scott Lambert. Unilateral cataracts are best operated by 6 weeks and bilateral by 6 to 8 weeks. Up to 8 to 10 weeks also can be bilateral cases. But if you prolong beyond that, beyond 3 months, they develop nystagmus, and then you cannot expect vision beyond 6 by 60. So now we know aggressive treatment of amblyopia with contact lens and patching can give good vision even in unilateral cases. There was a time when we used to say, if you do cataract surgery and if you leave them as a phakic, there is no point doing surgery. So now it's not so. Even unilateral cases can get good vision. So partial cataracts, the scene is different. Many cataracts look very subtle changes are there. If they are not visually significant. What is a visually significant cataract? This is a cerulean cataract. Some sutural cataract is there. Posterior polar, just sort of Mittendos cataract is there. Cerulean cataract. This is a little more than 3 millimeter posterior polar cataract affecting the nodal point. This is an anterior polar pyramidal cataract. So some cataracts affects vision. So a 3 to 4 millimeter central posterior polar posterior, which is affecting the nodal point, the posterior polar posteriorly located one, affects vision. And if it is obstructing your fundus view, definitely you have to do surgery. And if the child is presenting with a strabismus, then definitely you have to do surgery. And if the child has an nystagmus, these are considered visually significant. If there is an anterior polar cataract, there is just a small pinhead sized cataract, even with the pyramidal one, they don't usually affect vision, and even fundus examination doesn't obstruct your visualization. They can be watched after putting you can probably see them every 6 weeks with some dilating drops to see whether it is progressing. But all these scenarios, they don't progress clinically, but you can bring them back in 6 weeks to 3 months and see whether there is any progression. Even mitten dots, they don't progress, but posterior polar look for progression. At a later date, they may progress into the first or second decade, first decade or second decade. So, coming to evaluation, bilateral cases, family history is very important, and examination of the family members also. In the parents, it's very important to look at the parents also. Genetic causes can be the reason in about 50% of the cases. And in our scenario, infection is a very important cause. Torch titers have to be done. Aminoaciduria, galactokinase deficiency is not very common, but often they have other systemic associations like liver pathology, low weight gain. All these problems are also there. So, reducing substances in urine, all these things can rule out metabolic disorders like galactokinase deficiency. In a unilateral cataract, you have to look more for pathology in the eye, like PFV, persistent fetal vasculature, posterior polar cataract, posterior lenticonus, rubella. Rubella also can present unilaterally, trauma, posterior segment tumors, and sporadic sometimes. So, what we have seen is persistent fetal vasculature is a very, very common cause for unilateral cataract. So, you have to be on the watch out for any persistent fetal vasculature and rubella and its associations. So, often in both these cases, the eye may be microphthalmic in PH, persistent fetal vasculature, not so much. Still, often we see the eye is microphthalmic compared to the other eye, and they can go in for glaucoma at a later date. So, they need more close follow up for development of amblyopia as well and glaucoma development. So, they need more frequent follow up of refraction and glaucoma. So, some challenges in rubella cataract. Rubella used to be the more common infectious cause. An LVPI study recently showed that more than rubella, it is the CMV that is coming up. Even in our study also, we have shown that CMV titers are more, 24% and 22% rubella after the rubella vaccination has become more prevalent, I would say. It has not become compulsory even as yet. So, microphthalmia, myotic pupil, calcific capsule, all these are problems we face when we do surgery for rubella cataract. Corneal opacity may be there. Rather more than corneal opacity, I would say corneal haze is common. And glaucoma, pigmentary retinopathy, all these things affect their visual outcome. So, and also pre and post-operative anesthesia challenges in the rubella child. So, modern safe anesthesia has made it possible even to take up the surgery for cataract even immediately following cardiac surgery. We do surgery, they send us patient immediately the very next day saying he is fit for surgery after PDA ligation. So, we do surgery next day, but we do have to follow them up. We send them back for an ICU monitoring for 1 or 2 days. Surgery may be, we have to get prepared for hypothermia, postoperative apnea, hypothermia, and sometimes anticholinergic syndrome after using even hometropin, not even atropine. So, an ICU management may also be necessary. We have a hypothermic, this warming sheet for the baby for the during anesthesia. So, ophthalmic evaluation, of course, we have to do an on the table before surgery. In some cases, you have to rule out intraocular pressure also, like rubella, Lowy syndrome. There may be an association, especially when you see a hazy cornea, you have to rule them out also. And biometry, axial, like I think I will rush. So, visual access opacity, you have to do an examination under anesthesia before surgery, and sometimes axial, you can do ultrasonography even before anesthesia to look for any posterior segment tumor or posterior segment fetal vasculature. Even without anesthesia, you can do. So visual axis opacification is the single most important complication which reduces visual acuity and lead to amblyopia after cataract surgery. So PPC is a must, and the technique I am not going into. And this is what our experience, that there are plaques which may be a residual remnant of PFB. 60% of our unilateral cataracts have these plaques, which may be due to PFB. Often we are able to put an implant an IOL. This is an we use endo cautery for these vascularized fetal vasculature which we see on the cataract, and then go ahead with cataract surgery so that we can prevent bleeding. But before that, we have to rule out any posterior solely posterior vascular form of PFB when posterior segment surgeon will take over. So the whether we will implant an IOL or not before 6 months, the IATS has shown that it is the visual outcome is more or less same, but you may need more number of surgeries due to the membrane formation. But you have to know that the study which they did, they had to provide about 9 to 11 contact lenses during the first year after surgery, which was included in the study, which is not possible in our situation. So contact lens is not very feasible in our situation. So if the parameters like corneal diameter and the axial length, they are not microphthalmic, then probably even before 6 months you may be able to implant an IOL, because the amblyopia management becomes easier. But after, even before 2 years, after 6 months, the extension, as an extension of the IATS, infant aphakia treatment study, the toddler aphakia and pseudophakia study, tabs have shown that IOL implantation is good. All this is because the cornea flattens from 52 to 43 diopters, 34 to 18 diopters of lens power, axial length from 17 to 22 millim. All this happens within 1 year, the first 1 year. That is why there is lot of unpredictability during the first year. That is why implantation is better deferred in these cases. But of course, management is difficult when there is a unilateral aphakia with contact lens, and patching is always difficult. So if it is possible, it is better to implant an IOL. And secondary procedures, when you have to do a secondary IOL, in the sulcus, 3-piece IOL with an optic capture as you see here, or membranectomy may have to be done. And follow up is the most important. We have what I call, in our part of the place, Malabar, we have the Gulf syndrome. After cataract surgery, they just go to the Gulf and come back after 3 years with a thick membrane formation, no change in refraction, sometimes glaucoma. You see, this unilateral glaucoma, unilateral cataract child had a microphthalmia, and they thought the eyes are becoming equal in size, and were very happy that they are becoming normal, and they didn't bother to come. And then he went in for glaucoma. Glaucoma was there advised, but they didn't come. So all the refractive growth is very unpredictable in a child unless patching is done with the refractive correction. The unilateral cases can land up with dense amblyopia and all the risk we have taken during the first 3 months for surgery will become futile. And posterior capsule opacification and secondary glaucoma are still the major post-op complications. So long-term follow-up and counseling, each time you have to reinforce the need for follow-up each time. So thank you.
Thank
Sorry
you,
for
Leila.
taking longer time.
Not at all. Yours was a keynote address, so we have allotted 10 minutes, I think. Yeah, thank you very much, Leila ma'am, for that very clear, insightful talk on abnormal red reflex and on